All right. So my name is Allison Sela. I am the medical director for intensive care and cardiopulmonary services, as well as pulmonary rehab at Preston Memorial Hospital in Kingwood, West Virginia. And today we're going to talk about chest radiology. So I've got a lot of slides to get through, so I'm going to go sort of fast. So the point of getting imaging studies is to recognize an abnormality. You're looking for some variation from normal. You want to be able to characterize and localize that abnormality. When you're looking at an X-ray, the first question you want to ask, is the X-ray acceptable? Can you see the anatomy of the lungs? Are you able to differentiate the lobes and the fissures, the mediastinal structures, the airways, the vasculature? We'll talk a little bit about signs such as the silhouette sign and air bronchograms. Then we'll also work on identifying lines, tubes, and drains. And then we'll talk about different disease processes if we have enough time. So the goals for today, I'm not going to really read these out to you, but basically we're going to talk about the different terms that go along with chest X-rays and why it's important to determine if your X-ray is good or not. We'll talk a little bit about anatomy and some abnormalities that you can see in an everyday X-ray, and then we'll talk a little bit more about different types of diseases and pulmonary nodules. So this is a picture of a chest X-ray. This is a PA view. So you're taking a posterior anterior view, and this is on the right what it will look like from that view. And that is opposed to this lateral view. And you can see that you're shooting the X-ray from the left side of the patient through to the right side of the patient. And then the view on the right is what you're going to see. So this is an example of a normal PA chest X-ray. And it has some landmarks differentiated for you here. You can see the spinal processes are located here. As you get further down into the mediastinum, you've got your airways, your esophagus, you've got your heart and some other mediastinal structures, and so it becomes difficult to see these spinal processes as you go down. Remember, when you're talking about imaging studies, that anything that is dense is going to be white, and anything that is not dense is going to be black. And so that's why the lungs, which are filled with air, are going to be darker than the bones, which show up white on this X-ray. You can see up here at the top, you've got the clavicles, the scapula over here. The anterior ribs, I always thought were difficult to determine, difficult to differentiate, but this is an anterior rib here, and the ribs that you see that are much more easy to identify, those are actually the posterior ribs. When you are looking, you can see that this sort of dark strip here, this is the trachea, the windpipe, and when you get down here to the carina, it branches here into the left and the right, and you can sort of see this black outline sort of continues down. You get into the hilum here, and you can see all the vasculature here. This is the right atrium of the heart, and then you can see the descending aorta here. This outline here that extends sort of beyond the film is the outline of the breast tissue. The diaphragms here and here. Under the left diaphragm, there is a gastric air bubble. Under the right diaphragm is the liver. When you get a chest X-ray, you want to make sure that the patient has a full inspiration. This can help to determine whether there's any intrapulmonary abnormalities. And in order to determine whether you got a good X-ray, the diaphragm should be located about the level of the 8th through the 10th posterior rib, or the 5th to 6th anterior rib. And so if you count your posterior ribs, you've got 1, 2, 3, 4, 5, 6, 7, 8, 9, and then 10 comes off here. So this is a good inspiratory film. You can see we're somewhere between the 9th to the 10th level with our diaphragm. This is an expiration film. And so you can see on the left, the expiration film versus on the right, you've got an inspiratory film. And so you can see that if you get an expiration film, while you might think that this patient has all sorts of pathology going on, this over here looks like a pneumonia. But when the patient takes a nice deep inspiration, that area of the lung clears up. And you can see that there's no pneumonia located in this area. The next term that we're going to discuss briefly is penetration. And so penetration has to deals with how much of the X-ray is shot through the patient. And so the goal is to be able to see the thoracic spine disc spaces barely through the heart. Usually you cannot see the bony details of the spine other than where we pointed them out up here at the very top of the X-ray. You can see the bronchovascular structures through the heart, and you can see that through here. You can see this vasculature. And on the lateral view, the spine should darken as you move towards the head. And you can see that it gets more white as you move towards the head. You should be able to see the sternum on the lateral view, and you can see this area right here. This up here, this is all soft tissue density, breast and arms that you can see. The left film on this is a film that is underpenetrated, and the right is an overpenetrated film. And so here you cannot make out any of the differentiation between the vascular structures or the airways or anything in the general mediastinum. You can even see that the outer edges are a little bit blurry. On this film, it's overpenetrated, and again, you can't see any of the vasculature or anything in the lungs anywhere. They just look like two black blobs. So what we ideally want is somewhere in between these two. Something like this particular X-ray. The next term we're going to talk about is rotation. And so it's very important that the patient is placed flat against the cassette when you're getting the X-ray. If the patient is rotated, the mediastinum or the structures in the middle of the chest may look unusual. And so the best way to look at that is to look at the clavicular heads. And the clavicular heads, which are up here and over here, they should be equidistant from the spinous processes. So here's the spinous processes, and they should be about the same. Now, if this one is here and this one's up here, then the patient is likely rotated. And that you can see here. You can see this clavicular head here and this one over here. And so when you look at this, you may look at this X-ray and think, oh, this patient's got some sort of big mass in their chest. What's going on? Is this a pneumothorax? But again, the first thing you want to check, the things that we talked about, penetration and rotation, and this patient is clearly rotated. And sometimes, when we've got a patient in the ICU, they're on a ventilator, the X-ray tech is shooting 15 X-rays, early in the morning. They don't always ask for help. And so this is the type of X-ray that you can sometimes see. This is actually a skin fold here that can be mistaken for a pneumothorax. So again, the objective of getting a chest X-ray is to be able to detect an abnormality, to describe these findings as clearly as possible so that you can help to differentiate what the diagnosis may be. And so in both of these X-rays, you can see a left upper lobe abnormality. And when you're talking about an X-ray, the top X-ray here, this would be defined as a well-defined mass in the left upper lobe, versus this one is a poorly defined opacity. And so you can see that by correctly describing what you see on the X-ray can really help to put into your mind what the differential diagnosis may be and what types of things you need to look further into and try and rule out. Location is also important. Masses can have 3 different locations within the thoracic cavity. And this slide shows an intraparenchymal or within the lung tissue at A. B is a pleural mass. So you can see that it's affixed to this lining of the lung. And then C is extrapleural, and this looks like it originates from the chest wall. This slide shows 2 CT scans. On the left, we see a pleural-based mass, and on the right, we see an extrapleural mass. And again, how these are described by radiology or by whoever's interpreting the images can help you to determine a differential diagnosis, and then help you to sort of narrow down what diagnosis you may be looking at and what tests and studies you might need to do next. So anatomy, our lungs, we have a right lung and a left lung. The right lung consists of the upper, middle, and lower lobes. The left lung consists of the upper and lower lobes. We have fissures, the oblique, and the minor or the horizontal fissure. What is a fissure? It's a groove. You can see it on the x-rays, and basically it serves to separate the lobes of the lungs, the upper from the middle or the lower. The transverse fissure divides the right middle lobe from the right upper lobe. And the oblique or major fissure divides the right lower lobe from the right middle and upper, and the left lower lobe from the left upper lobe. And this is a frontal view of the lobes. This minor fissure here, again, is going to divide your right upper lobe, your right upper lobe from your right middle and lower. This is your oblique fissure here. And this is the superior border of the oblique fissure. It's a little bit easier to see on the lateral views. Here you've got your oblique fissure and your minor fissure. You've got your right upper lobe, your right middle, and your right lower lobe. Here on the left, you've got your oblique fissure dividing your left upper from your left lower. And when you put that together, both on the PA view and the lateral view, you can really start to see the shape of the lobes of the lung. This photo demonstrates, or x-ray demonstrates, the right middle lobe, which is so nicely highlighted in green. And you can see that you've got a border, a fissure here, which corresponds to this fissure here, and then the oblique fissure here and here. And so this, along with the heart border, outlines your right middle lobe. In this image, you can see some fluid in the fissure, and that's really a good way to be able to point out these fissures to people that may be looking at images for the first time. You can see on the image on the left, you've got fluid right here, and it really follows along in that groove. There's fluid down here as well, and it tracks up and it goes to the path of least resistance, and so it flows into this fissure. And the same here, you see the fluid line here. This patient also has a valve replacement. On the CT scan, it appears like a gray line. It looks different from your vasculature. You know, it starts and stops on either end of the lobe, and so again, it's a groove. Without being any fluid in it, it looks very unassuming and small like this. Obviously, when there's fluid, it does take on a different appearance. This is an anatomical specimen, and you can see, again, we're talking about this horizontal fissure here and the oblique fissure here. This is a drawing from Netter's. You can see the fissures here and here. And then this right here corresponds to this vascular bundle where you've got arteries and veins and lymphatics all flowing through this area. This is the left lung. Again, you can see this fissure corresponds to this line right here, and then the vasculature bundle. This is an example of a pathology in the right middle lobe. And so if you look at this patient, the left lung looks okay, the upper right lobe looks okay, but you can see down here there's a hazy aspect. And again, it's a little bit clearer in the lateral view. You can see that there's something going on in the right middle lobe. Over here, again, it looks clear. And again, we're following those fissures. This outlines the mediastinal structures, the right innominate vein, superior vena cava, ascending aorta. The right atrium is here. You can see the diaphragms here. The descending aorta is here. Left ventricle, left pulmonary artery, aortopulmonary window. You can see the knob of the aortic arch, and then the left innominate vein lays within here. And this is important because these things help to define our lung borders. So our right upper lobe border is along the right innominate vein, the superior vena cava, the ascending aorta. The right middle lobe abuts the right atrium and the diaphragm. The right lower lobe along the diaphragm. The left lower lobe also along the diaphragm. The lingula is here along the left ventricle. This border here corresponds with the border of the lingula. And then the left upper lobe up here with the aortic notch. The trachea and the main bronchi, I pointed those out earlier on, but the trachea usually starts at the top of the film and works its way down to the carina, which is where things branch into the right main bronchus and the left main bronchus. The carina lies just below the aortic arch. And then you've got the right main bronchus that divides within the mediastinum. The first branch that comes off of the right main bronchus is going to go into the upper lobe. And then you've got the bronchus intermedius, which is here, which would divide into the middle and the lower lobes. The left main bronchus over here also goes to the upper lobe, which supplies the lingula and then the lower lobe. This is just another view of that. You've got the azygous vein here, the right main stem, the left main stem, and the carina. And this is a picture of the bronchi starting from the, well, you've got the trachea and the carina here, which aren't labeled, but we go into the right main stem and then up into the right upper, the right bronchus, the bronchus intermedius, which goes into the middle and the lower, and then the left, which goes into the upper and the lingula, and then into the lower. And those are broken down further and further and further, but I'll leave this here just for your reference. And this photo shows pulmonary vasculature, just for another point of view as to what we're looking at on the imaging and why these particular areas may tend to be a little bit more dense on imaging. This shows a little bit closer the pulmonary vasculature and how everything really overlies. Here's your trachea with your carina, and then you can see all of your vasculature here, the left atrium, the pulmonary veins, and so everything again is very dense right in the center of the chest, which why it's sometimes a little bit more difficult to differentiate between structures there. And sometimes a CT scan may be a better option if you're looking at something in the mediastinum. This shows the pulmonary artery on the left and the right pulmonary artery here in a CT view. So next we'll talk about something called the silhouette sign. And what the silhouette sign is a loss of the normal border between structures. So we talked about the right middle lobe abutting the atrium, and then we talk about the right lower lobe along the diaphragm. When you lose that border, it may be an indication that there's some type of pathology happening there. So, for example, the upper right heart border and the ascending aorta, if there is a loss of this border, this contacts the anterior segment of the right upper lobe. And so that may lead you to think that there's some type of pathology in the right upper lobe. Again, if you lose the right heart border, you're concerned about the right middle lobe, the left heart border, the anterior segment of the left upper lobe. If you lose the left heart border, that bordered the lingula. Aortic knob is the apical portion of the left upper lobe, and the anterior hemidiaphragms are the lower lobes bilaterally. And this is, forgive the labels on this, this was the best picture that sort of outlined all of this. But these are the areas that I just mentioned on that last chart. So if you lose the differentiation in this area, you're concerned about a process in this particular aspect of the lung. This X-ray shows loss of this this clear outline here. You can't really see where the heart border ends. This abuts the right middle lobe. And so again, we're looking at a right middle lobe process. Air bronchograms are tubular outlines of the airway which is made visible by the presence of fluid or an infiltrate. You can see this in lung consolidation, such as a pneumonia, non-obstructive atelectasis or collapse of the lung. You can see this sometimes in severe interstitial disease, in neoplasms, as well as in normal expiration. And so what you can see here is you can see this tubular outline. It looks very similar to when we were looking at the trachea, how you can see the black stripe. You can really sort of make out that there is a tubular outline of an airway going down through here. It's a little bit clearer on the CT scan. You can see these airways sort of branching. But what this means is that there's some sort of fluid or something infiltrate or something along the outside that is not affecting the airway, and so it leaves this sort of black stripe. Here you can see air bronchograms here and here. When you look from the lateral view, keep in mind that these things are going to be turned on their side, so they're going to be round, and it's sort of like you're looking down the airway. And so you can see here, you can see here, you can see some smaller air bronchograms here. Again, they're going to be circular in the lateral view, and they're going to be tube shaped in the PA view. So next we'll move on to lines, tubes, and drains. So different lines that you may see on chest x-rays include an IJ triple lumen catheter, a subclavian triple lumen catheter, a PICC line, a tunneled catheter, a port. Tubes include an ET tube, a tracheostomy, or an NG tube, and drains such as a pigtail drain or a large bore chest tube. So on this x-ray, this patient has, these are all EKG leads. You can tell by this sort of M-shaped clip with the wires extending to it and tangling off to the side here. But this is, they have an IJ, and that is what this line is here, that follows down the mediastinum and ends right about this area here. This is an external tubing going off of here. This is a left IJ. So again, you're going to think about the placement where your internal jugular vein is. And so that's going to be up here in the neck, but it's got to get to the, it's got to get to the same place that the right one went, which is all the way over here. So it's going to have to cross the midline. And so you can see this line coming across here and going down and ending probably right about there. Again, you've got some EKG leads and some external tubing up here. Subclavian, this is a left subclavian. And again, think about where your subclavian runs from. You can see that this line comes across here and ends here. This is a PICC line. So a PICC is peripherally inserted central catheter. And so it is inserted into the arm, and it travels all the way up the arm, and it curves around and gets a little hazy in here, but I believe it ends somewhere, I think maybe here. This is a tunneled catheter, and so this is a catheter that can be used for dialysis, and so it's going to be a larger bore, a larger catheter, just because of the functions that it needs to perform. This port right here is actually external, and then it's tunneled under the skin and ends right here. This patient has a port. Ports are easy to differentiate. They have a triangular shaped head with a catheter that comes off of it. This port is actually accessed, which means it has a needle in it. This patient is getting some type of infusion. And the way that you can tell that is within this triangular head is this bright white thing. And this is the needle that they use to access the port. One of the attendings when I was in fellowship always used to ask the question, is the port accessed to the residents? So, but this one is. Endotracheal tube placement. This patient has an endotracheal tube. And what you're looking at here is you are looking at a tube that's going to be within the trachea. So we're looking midline. Notice that this patient is rotated. The clavicular head is here on the left and over here on the right. So this patient is rotated. But this patient has a tube that is within the trachea. It has these stripes on it that show up on the X-ray, so you can determine where the tip of the ET tube lies. You're looking for placement about a couple centimeters above the carina, which is right here. Too far down and you can end up with a right mainstem intubation, such as this picture here. You can see this tube right here makes a nice curve right into the right mainstem, which is not what you want. And because of that, actually is probably more so in the right bronchus intermedius, because you can see the right upper lobe here has a very similar appearance to the left lung. And so this tube is probably in the right bronchus intermedius and is not providing air into the right upper lobe or the left lung. This patient has a tracheostomy. You can see this nice dark circle here, and then they have a tube that terminates right here. This patient has a nasogastric tube. Which is difficult to see on here, but it comes right in through here, I believe, and goes into the stomach. Sorry, that's not a very good image. I probably need to find a different one. This is a misplaced nasogastric tube, which is going in the trachea, past the carina, through the bronchus intermedius, and right down here into the bottom of the right lung. This is why we always get X-rays prior to starting tube feeds. This patient has a pigtail catheter named for the curve in the end of the tube that appears like a pigtail. This tube has small perforations all along here, which help to drain simple fluid. And that is opposed to a large bore chest tube, which you can see here, which would drain more complex fluid, something that was thicker that would not necessarily be able to drain through the small pigtail. And this break in this line here is actually one of the side holes in the tube. So X-rays can show us a lot. They can show us all sorts of different pathologies, such as atelectasis or collapse of the lung. It can show us edema, pneumonia, other types of infections like tuberculosis, pulmonary hemorrhage, pulmonary embolism, pleural effusion, pneumothorax, interstitial types of lung disease. There are some hints on X-rays that can lead us to the diagnosis of COPD or emphysema. We use them in trauma. We can look at mediastinal masses, pericardial effusions, pneumomediastinum, diaphragmatic hernia. So X-rays, even though they're not the newest technology, really can point us in the direction of all sorts of different types of diagnoses. Now, they're not necessarily the best for all of these diagnoses. Sometimes getting a CT scan is going to give you more information, but it can certainly lead you down the right road. So atelectasis is a collapse or an incomplete expansion of the lungs. It's a very common finding. It can be caused by like a tumor or a mass that's within the airway, a mucus plug in the airway. It can be caused by extrinsic compression, either from a lymph node or peripheral compression from fluid in the lung. And then we see this entity called rounded atelectasis, which usually develops after a patient has had some type of inflammation in their lung. And it's associated with linear density and volume loss. You can sort of see down here at the bottom of the lung, there's some atelectasis where the lung's not fully inflated. There's some atelectasis here, some atelectasis here. This image shows some left upper lobe atelectasis. And so remember the borders of our left upper lobe. Again, you've got your oblique fissure here. And so it's going to be up at the top. You've got your aortic arch and your other borders of the left upper lobe. And so when you lose those borders, you're going to be concerned about a process in the left upper lobe. And so you can see this outline here You can see this outline here. This is, you really can't see anything in the left upper lobe. You've lost that, you've got that silhouette sign there. This is the same finding in the left lower lobe. You can see here, you lose really this definition of the left heart border. As compared to this, when this atelectasis has resolved, you can see clearly the diaphragm where you could not see that over here before. This is the right upper lobe, and again, you've got the mediastinal structures up here and the anterior border, and you can see here that there's a process going on up here in the right upper lobe. And when that happens, oftentimes there's elevation of the transverse fissure that gets pulled up this way, as demonstrated with these arrows here. Right middle lobe, we've talked extensively about this. You lose the right heart border here. Which you can see there's not a very clear outline here. And you can see this process occurring here as well. This is the right lower lobe. You lose the clarity and the definition along this border, as well as along the diaphragm. So pulmonary edema, this is when you have increased pulmonary vasculature and an increased heart size are often also seen. You can see these lungs might be described as sort of fluffy. There's all this sort of white stuff happening in here, and what that is it's fluid within the lungs. We talked earlier about looking for air bronchograms, and you can certainly see over here on the left there is an air bronchogram here. This here I think is the fissure, but you do have sort of increased vascular markings. The heart border you can see here and here. This heart looks bigger than the hearts that we've seen on some of the other x-rays, which is typical for a patient with congestive heart failure in whom you might expect to see pulmonary edema. And so a rule of thumb that the radiologist uses is that the heart should be equivalent to half of the mediastinum. And so if you took the heart in this picture with your borders here and here, and you shifted it to one side, if the heart extends past the midline, then the heart would be enlarged. And so with this patient, it does appear that the heart would be enlarged. This is another pattern of pulmonary edema called the bat wing pattern. You can see where the edema is worse out here in sort of a bat wing type appearance. This is other pictures of pulmonary edema where the lungs are very fluffy. And again, sometimes it's hard to tell, is this an overpenetrated film? And so looking, you can see your ribs, you can see your trachea up at the top, and then everything tends to get a little bit darker here. So I think this film is penetrated appropriately. It's just these patients are full of fluid. For patients with congestive heart failure, what we're looking at is cardiomegaly, or an enlarged size of the heart. And you can definitely see here with your right heart border and your left heart border, this heart would take up more than half of the chest. And so this heart is enlarged. You can see alveolar edema. You can see increased vascular markings. This is a patient with congestive heart failure. So the next disease is pneumonia. With this, we're looking at an airspace disease and consolidation. You can see an opacity, a lobar consolidation, interstitial opacities. These are usually space-occupying lesions, which mean they take up that space, but they don't cause loss of volume within the lung. There may be a pleural effusion or some fluid in the lung related to the pneumonia. And again, the presentation on the x-ray can help determine the likely cause. So if it's a lobar pneumonia, you would think more so of pneumococcal pneumonia versus a lobular pneumonia, which tends to be more staphylococcus. It can be patchy or multifocal. Interstitial pneumonia, if it's described as an interstitial pattern, you want to think along the lines of viral or mycoplasma. An aspiration pneumonia is going to follow gravity, so the lower lobes tend to be more affected. And then for diffuse pulmonary infections, you want to think about things like community-acquired nosocomial, like Pseudomonas, or ventilator-associated pneumonia, or in immunocompromised patients, you want to think about fungal or PJP, PCP. So here, again, we're looking at the right middle lobe. And you can see here that the borders are very indistinct, although you can make out that it is lobular. It doesn't, it can sort of extend beyond that. There are air bronchograms specifically seen in this section of the lung. And then the silhouetting of the right heart border. So you've lost that right heart border. This is a right upper lobe pneumonia. You can see this area here is affected. Tuberculosis can show consolidation, adenopathy, or enlarged lymph nodes. You can see a pleural effusion, and tuberculosis tends to involve the upper lobes. In pulmonary hemorrhage, this is an airspace filling process. You can see that there is this process right here, and there's something down here in the bottom of the lung. For pulmonary embolism, this is usually very difficult to spot on a chest X-ray. And you know, the standard to diagnose the pulmonary embolism is a CT scan. But when you do see something like this on the X-ray, you want to really, what you're looking for when you get an X-ray for a patient that you suspect pulmonary embolism is to rule out any other cause of shortness of breath or hypoxia. Excuse me, do they have a lung collapse? Do they have a major pneumonia? And so in the absence of any abnormalities on chest X-ray, that would be the time to consider, you know, could this be a pulmonary embolism? Let's send the patient for a CT scan. Now, you may see something called a Hampton's hump, which is a rounded opacity, which is what we see out here at this lateral wall. Very rare to see that with a pulmonary embolism. It usually has to be pretty significant to see that. And it usually appears later on. It doesn't appear usually in an acute pulmonary embolism. Again, CT scan is the best method to look at a pulmonary embolism, a CTA. And you can see here, you have your vasculature, which is sort of this light gray color, which you can see up here. And then you can see this darker gray here below it. And that's actually a blood clot sitting there. And this one, you can see this blood clot sitting here. And you can see that there's no flow beyond this blood clot. So you don't see any vasculature anywhere in the lungs over here. Pleural effusion or fluid in between the lung and the lung lining. Common causes of this are congestive heart failure. You can also see it with infection or after a trauma, pulmonary embolism, cancer, or with renal failure. And what you'll see is blunting of your costophrenic angle. And so you can see here that normally the costophrenic angle, I apologize, I don't have a normal film on this X-ray, but normally the diaphragm curves down here, and you have a part of the lung that sits in this area. And so here you can see that you've got this curve here, and this is all filled with fluid. You can see that here as well. You've got a curve here when normally you should see lung tissue down in this wedge-shaped area. This is an example on a CT scan of what this pleural fluid looks like. This large gray area is fluid pushing on and compressing the lung, which would lead to this area here, which is what we'd see as atelectasis. And that is opposed to this over here where you see an abscess in the lung. And this is actually lung tissue that's diseased or inflamed with a nice cavitary lesion here in the middle. Pneumothorax is when there is air inside of the thoracic cavity, but outside of the lung. And so this looks like an area where there's air. However, if you look closer, there are no lung markings in that area. It's found outside of the white line of the pleura. If the patient is standing or sitting upright that air is going to travel up, and so you'll see it up at the top of the film. It's very difficult to see if the patient is lying down. So on this film, you can see this red arrow points to this white line, which is the pleural lining, and you can see that just beyond that, there is a small strip of air. It's difficult to see any lung markings in this X-ray, but this would just appear like an area of air without any lung markings because there's no tissue in this area. It's just an open space. This is a much more, I guess, much less subtle example where you've got a tension pneumothorax. And so you can see very clearly there are lung markings here, there's lung markings over here. This is an area of air with no lung markings. This is a tension pneumothorax. This is a big pocket of air here, which has caused everything to sort of shift over to the side. You can see the airway is shifted. You can see all of these mediastinal structures are all shifted over to the left. And so this can put compromise on the lungs, can put compromise on the heart as a medical emergency. And that's why these are decompressed with a needle going into this space to drain all of this air out. And then everything will shift back into space, into its right place. This is a pneumothorax here along the mediastinum. You can see this white line of pleura, and the red arrows are pointing to this empty space where there are no lung markings. One other thing that you can look for on a chest X-ray, in addition to, just searching for these pleural lines, is something called the deep sulcus sign. So when we were talking before about fluid, I mentioned how the lungs sort of go down along the diaphragm, which looks sort of normal here, sort of normal over here. Over here, you can see what we call the deep sulcus sign, which means that this air extends way down here. And that's a common finding for a pneumothorax. This is a hydropneumothorax in which fluid and air fill this space. And so with that, what you usually see is an air fluid line. And so you can see here on the left that you have this line of fluid across here. You've got a pocket of air above it, and then the lung tissue here. Again, there's lung markings here. There's no lung markings in this pocket here. This is what it looks like on a lateral view, where you've got this fluid collection that does not follow any borders. It just sort of sits across there. And the same thing here, you've got this line of fluid that does not follow any borders. And so the way I explain this is if you take a bottle of water that you have in front of you, and when it's sitting upright, you've got the line where the fluid is. If you took that bottle of water and you laid it on its side, you've now got the line going across. And so that's sort of how I explain the difference between here and here. There's no borders that prevent this fluid from flowing freely within the chest. And so you can see these shifts in the fluid line like you see here. We can also see pulmonary fibrosis on chest X-rays. These patients usually present with exertional dyspnea, a non-productive cough. They usually have equal and bilateral volume loss, and then linear opacities bilaterally. And so you can see some of these areas here in the lung show some scarring or fibrosis. Usually it's at the bases of the lung first is where we tend to see this. We talked earlier that some signs of emphysema and COPD can be seen on chest X-ray. These patients, especially patients with emphysema, have a loss of elastic recoil. So when they exhale, they're not going to fully empty their lungs of air. They also have destruction of pulmonary capillaries and alveolar septa. And so with that, with this damage and destruction to the lung tissue and not being able to fully empty your lungs of air, you can see hyperinflation. And that is evidenced on chest X-ray by an increase in the retrosternal space. So you can see here on this bottom X-ray, you can see the chest bone, the sternum here, and then you can see this large black area directly behind it in front of the heart and the mediastinal structures. And so there's increased, we call it the increased retrosternal space, but there's increased lung tissue here. You can also see flattening of the diaphragms, which is evidence on this upper X-ray. So instead of having a nice hump to the diaphragms, they're very flat. You can see increased space between your ribs because the lungs are overinflated. And so the ribs appear like there's more space in between them. Sometimes you can even see bulla or large air pockets within the lung as well. We use x-rays in trauma patients specifically to look for rib fractures. And this is where there's an abrupt discontinuation of the smooth contour of the ribs. So the ribs, you know, again, you've got your anterior ribs and you've got your posterior ribs, and they should have this nice smooth border. When you see that that's interrupted, such as over here, there is a fracture to the ribs. When you have multiple ribs in a row that are broken, you worry about something called a flail chest. And so if you've got several ribs in a row that are broken, this aspect of the chest can really sort of move independently on its own, which puts the patient at risk for having a puncture of the lung and can be life-threatening. We can use a chest x-ray to diagnose an anterior mediastinal mass, such as a lymphoma, thymoma, teratoma, or a thyroid mass. You can see here that something is clearly not right. When you look at the lateral view, you've got something happening here. When you look a little bit closer on CT scan, you can see there's something going on here. It becomes a little bit clearer as we move down in the series, and there's this mass here, which corresponds, well, not exactly to this X-ray because it's really over to the left side. Mediastinal mass can also be seen. Again, you're going to lose some of the borders and the clarity on your X-ray. This doesn't become quite as sharp as it was before, and that corresponds to a mass in this area. This one happens to be a saccular aortic aneurysm, and you can see this gigantic. It looks like a mass, but really a sac where the aortic aneurysm has bubbled out. Posterior mediastinal masses can also be seen, cancers, lymphadenopathy, aortic aneurysms. You can see here, we've got this rounded area here. You can see here, this border does not look like it normally should, and that corresponds with this area here. Other types of masses, we talked about these before, can be, you know, within the lung itself, associated with the pleura, or external to the lung. Pericardial effusion can be seen. This is fluid around the heart. Generally, these are going to be our CHF patients or trauma patients. In CHF patients, their heart is going to be gigantic, which you can see here. And here, there is a line here, which is the pericardial pleura, and then there's fluid within that. Pneumomediastinum, there is air within the mediastinum. This can happen in asthma patients. This can be post-operative. This can happen in trauma patients. If you've got abrupt changes in our intra-abdominal pressure, if patients need a significant amount of support from the ventilator. And so what you can see is up here, you can see this line of air that follows along the mediastinum. It's a very streaky appearance. It may extend all the way up into the neck. And you can see on the CT scan, this air within the soft tissues of the neck. You can see it outlining here just alongside the trachea. Here in the mediastinum, you can see all these black streaky areas with no lung markings. Diaphragmatic hernia, you can see a gastric bubble appearing up into the chest. Sorry, I'm sort of zooming through these. I've only got a couple minutes left. Hilar adenopathy, so increased lymph nodes, have this appearance here. There's some increased structures here and over here. We can see this with infection. We can see this with cancer. We can see this with sarcoidosis. And then pulmonary nodules. Usually if these nodules don't grow for 2 years, or if they're calcified, there's more likelihood of them being benign or non-cancerous. And that can include a granuloma, carcinoma, a rounded pneumonia. You can see this nodule clearly here. You can also see lung cancer. It has a sort of a nasty appearance where there's all these spiculations coming off of it. It's not perfectly round. It's not calcified. You can see a mass here. So in summary, chest x-rays are going to provide additional information about the patient's current condition and their disease process. You want to look at inspiration, penetration, and rotation to determine whether your x-ray is acceptable. They help you to determine whether you've got appropriate placement of lines, drains, and tubes. And then they can also help you develop a differential diagnosis for the patient's disease process based on common presentations of that disease on chest x-ray. So I know I zoomed through those quite quickly, but I'm happy to take any questions if anybody has any questions.
Thank you so much, Dr. Sela, and you did great trying to get through those. You really did. It's impressive. Not gonna lie, and it's a lot of information, and really appreciate that. We did have a question, and apologize if I butcher any of these words. How does one distinguish atelectasis from infiltrate or consolidation?
Well, usually an infiltrate or consolidation tends to be a little bit more of a solid picture. So based on chest x-ray, you're going to see something that's a little bit more dense when you've got an infiltrate. But also, clinical picture. If somebody has an infiltrate or an infection or a pneumonia, they're going to have a white count. They're going to be coughing up mucus that's green or yellow. They might have a fever. They may appear sick versus atelectasis, in which you don't expect a patient to appear sick.
Thank you so much. Does anybody have any further questions regarding that or anything during this presentation or comments for Dr. Sela? Thank you. Grace Ann has to hop off. We did have appreciation from Dr. Stansberry and Lisa Emery before they had to hop off. All right. Well, we will get those slides to everybody, and please know that ask any questions that you might have. And there was a lot, but she did a wonderful job. So.
Sorry, it was so fast, but I wanted to make sure we covered everything.
It was great because you just go through the pictures. It's really great going through the x-rays. And we haven't had a case since March. So I am just asking anyone to please try and submit one before our next one. That's what really makes Echo Echo. And our next one will be on May 16th, and Dr. Stansberry is going to be discussing the best of ATS 2022. So really appreciate everyone's time, and I hope to see you soon. Thank you.
Thanks, everyone. Thanks, Dr. Sela.